My name is Osama Elzaafarany, and I'm an Egyptian doctor. I graduated in 2005 from Alexandria University. Then I joined the same hospital, Alexandria University, as a resident in oncology for 3 years. During this period, I got the master's degree in oncology. And then I joined the Alexandria University as a staff, where I was working as an assistant lecturer of oncology. I spent there 7 years to go to USA to chair in some basic research for brain tumor vaccination. And then I joined a new position here in Saudi since 3 years, in 2017 actually, as a medical oncology registrar. And I have been in Saudi Arabia and I'm currently working here now. Gastric cancer actually is not so common. Maybe the third most common type of GI cancers in here in the Middle East as well, at least. So it's not too common. And of course, we have some kind of genetic predisposition for the gastric cancer. Sometimes, which is the intestinal type. We have two main types. Intestinal type is mainly caused by some genetic alteration. As well as we know, the Lynch syndrome is one of the predisposing factors or genes in this disease. It's a common theory of cancer that a normal lining of the gastrointestinal tract, we call it the epithelium. And this epithelium or the lining, when it's exposed to a chronic irritation or something that irritates this lining, this can lead to some changes in the epithelium cells, the reaction for this stimulus. By time, this chronic irritation will lead to some kind of genetic alteration in those cells, so they become as cancerous cells. Well, just start by inflammation, thickening of the layer, then going to cancerous stage. As we know that gastric cancer is common in the eastern area like Japan, mostly Japan, because they have some kind of eating habits. They like to eat smoked food. Smoked food is one of the risk factors of gastric cancer. So when we come to the prognosis or response to treatment, there are many factors, not only one factor that we can depend on. We have many factors that we can depend on to make a prognosis or a decision. So in general, first of all, we should say that the stage, I mean that the first or early stages, like stage 1 and 2, would be more curable, and the advanced stage, like stage 3 and 4, the cure is less. Also, we should know that a performance status or the general condition of the patient, the age, all of these factors will contribute to the prognosis and the cure of gastric cancer. So in general, we as oncologists, we classify the gastric cancer patient into early stage or advanced stage. So early stages, we prefer to go for surgery, and either we do operative chemotherapy, neoadjuvant I mean, or adjuvant after finishing the surgery, according to some pathological criteria we see in the histopath or post-op histopath results. And for the advanced stage, now we have some changes. In the past, we treat those patients only with palliative chemotherapy. And now with some advances, we go for the target therapy. We do what we know as HER2 test, if it's positive. If it's positive, we go for the biologic therapy, which is trastuzumab. Now is one of the most important cornerstone in treatment of metastatic or advanced gastric cancer. And now the era of immunotherapy, in the last few months, we noticed that it have a good share in this. And so when we treat an advanced or metastatic gastric cancer, we have what's called the lines of treatment. By that we start by the first line, and if it's failed, we go for the second line, and then third line, and like this. And every stage or lines have particular medication to be used in this. Since many years, I was believing in this, that we should treat each cancer as a particular subtype. We shouldn't use one medication for all cancers. Every cancer is unique. By the time, we found that every cancer now has some features in genetic or some molecular changes in it. So when we depend on this, we can get better results. So, for example, the immunotherapy, we have some markers or biological or genetic biomarkers that will determine if we can use immunotherapy for this patient or not. One of this is PD-L1 receptor. When we use this one, if it is positive, so we can for sure go for immunotherapy for this patient. This is one example. So when we talk about the disease in the early stage before metastasis has occurred, so we have some preventive measures. Clinical trials and scientific evidence tell us that we can do some measures to prevent gastric cancer. From our side or the medical side, we use the adjuvant treatment like adjuvant radiotherapy and adjuvant chemotherapy as well in some indications. Also, recently, and interestingly, the management of all the habit that like dietary habits alteration can also improve the percentage of recurrence or relapse. Well, most of the oncologists all over the world obey some guidelines. We call it the international guidelines. Those guidelines will guide you to the standard of care for every disease and every stage of disease as well. So one of the most famous guidelines is the ASCO guidelines, or the American Society of Clinical Oncology. Also, we have the ESMO, European Society of Medical Oncology guidelines, and also the NCCN guidelines. I don't know the abbreviation of this, maybe national cancer like this, but it's very famous. Every oncologist knows the word NCCN guidelines. So mostly when we treat our patients, we should refer to those guidelines to match our patient with the particular advice or guidelines in this society. Since many years, when we are practicing oncology and giving our patient chemotherapy and radiotherapy, we are struggled with the toxicity and side effects of those medications. It's very horrible. Most of the patients cannot even continue the treatment because of those severe side effects. But now when we come to immunotherapy and target therapy, we are facing much less side effects in terms of incidence and severity as well. So we oncologists feel more comfortable to give our patients targeted or immunotherapy, not only for the reason of precision medicine, but also for the reason of side effects minimization. Well, so when you have a gastric cancer patient who was given his treatment and now is treated and is in cure now, we should also follow some guidelines of follow-up. So the visits should be determined. Maybe we use the 3-month visit in the first year, and after this we will make it longer. He should come to the clinic every 6 months. During our visit, we should do a history, a physical examination complete, looking for any complaints, specific complaints in this patient, and we should go for laboratory tests, the routine and some specific tests like tumor markers, and also the imaging. We usually depend on CT scans on our routine practice, detecting any recurrence or relapse. Well, carcinoid antigen or CEA, by abbreviation, is one of the tumor markers. And in general, tumor markers, to be simple, is some substances released from the tumor when it is in division or active. So we depended on the diagnosis and also in the treatment follow-up. Let's say that we have a patient that have a gastric mass and everything, or a liver mass, and we don't know where the origin, so we can do this and to help us or guide us to detect the primary tumor. And also if we have gastric cancer with high CA and this patient went to treatment, and then we can do this test to see the response. If it's going down, so this patient is responding to our treatment, so we can continue. So it is guiding us in diagnosis and in follow-up treatment response as well. And by the way, it also can help us in detecting the recurrence. Well, the recurrence has different shapes. Sometimes come in the same place of the stomach, which we call the local recurrence. And it sometimes come away. We call it the metastatic recurrence. Sometimes the recurrence come local or in the liver, in lung, in the peritoneal area or surface. All these are types of recurrence that we see in our practice. So it is the most interesting part of my life now, this YouTube channel. I established it actually 1 year ago. And this actually comes from my daily practice. I when I speak with my patients, cancer patients, and Middle East and Arabic speaking cancer patients, I found that they have like a lot of knowledge about the cancer. They don't know what is cancer, how they can treat, like this. So, and at the same time, they have repeated questions. Every patient is asking the same questions. So I was thinking about making a scientific source for this patient to educate them more about the cancer, methods of treatment, side effects. So when the patient comes to you, the doctor, has a background, good knowledge. So we can, based on this, and start our journey with him. Also, many of our patients getting severe complication from chemotherapy, and they don't know how to manage this. Just stay at home, vomiting, they're having diarrhea, and they don't know what to do. But if you have a source, we educate them what to do, when to go to the hospital, like this, or other expected side effects, so they will have some, knowledge, basic knowledge that will help them to save their lives in some situations. So this was the idea about establishing this YouTube channel. Yeah. It's challenging to transfer what is in books and in science to real life. It's some kind of art. Some doctors are gifted to do this; they can do easily, but some doctors need some help in this. Actually, there is no source for those doctors who need to learn this skill, transfer the science to real life, depending on their personality and so. So by time, what I can say about time, by observing the senior doctors, what they're doing, you will learn. And you will learn from your mistakes as well. This is my advice. Well, for the young generation, I have two advices. I would like them to know more about the specialty and if it will match their personality or not. And the second thing is to know that oncology is two parts, the surgical part and the medical part. And the medical part has three parts in it. One is the radiation oncology, which is totally different, and the medical oncology, which is some type of medical oncology that dealing with chemotherapy and systemic treatment and side effects. It also helps in the diagnosis and follow up the patient, but mainly the concern or the art of this part is chemotherapy and systemic therapies, how to give and how to manage. And the third part of the medical is the palliative care, which is dictated for the advanced patients who have some pain, some advanced cancer, and need some palliation of their symptoms like pain management and so on. So you should be aware of this two parts, which is one you are liking to join, and you should read more about the specialty. And my best advice for you is to sit with a senior doctor who practices oncology and learn from him what are the challenges, what are the advantages of medical oncology. Well, it's a difficult question actually, because I never imagine myself anything other than doctor. But if I have to answer this question, I would say that I would like to be an artist.